Welcome to the deep dive. Today, we're tackling a really high-stakes area of surgical pathology, and that is male testicular and scrotal disorders.
It's a field of extremes.
It really is. You have these immediate life or fertility-threatening emergencies on one hand, and then this, insidious and complex world of oncology on the other.
Right. And for anyone who needs this knowledge, whether you're a resident prepping for exams, a surgeon staying current, or frankly, anyone in medicine, what we're covering today is just foundational.
Absolutely essential. And what's interesting about this deep dive is the source material we're using. It's not just a textbook chapter.
No, not at all. It's a framework. It's a pedagogical guide that's been specifically built for rapid learning and, more importantly, retention. High yield is probably the best way to describe it.
And the person behind that framework is Dr. Senthil Kumar. He's currently an associate professor in the Department of General Surgery at AIMS Nagpur.
And he brings a ton of experience to the table. We're talking over 15 years post-MS. He's not just a surgeon. The material makes it clear he's a dedicated teacher and researcher.
His training really speaks for itself, too. MBBS from Jitmer, Puducherry, and his MS in General Surgery from PG Eimer, Chandigarh.
Both top-tier institutes in India. So you know the foundation, the core knowledge we're working from is absolutely rock solid.
But as you said, it's the method that really stands out. Dr. Kumar makes a point of crediting a key mentorship in shaping his teaching style.
He does, yeah. He gives a lot of credit to his mentor, Mr. Nilesh Lodhaji, sir, for what he calls invaluable wisdom.
And it wasn't just about surgical technique. It was about how to teach, how to make information stick.
Exactly. We're talking about things like innovative memory techniques, student-focused learning, even animation-based methods. The goal is to make this incredibly dense information digestible.
So that's our mission today. We're going to use this really clean, exam-ready framework to pull out the most critical information you need to know. It's a shortcut, really, to the logical flow a surgeon needs at their fingertips.
And there's only one place to start:
The foundation.
the surgical anatomy.
Let's get into it. To understand why things go wrong in the scrotum, you first have to understand how it's all put together.
It all starts with the blood supply in the spermatic cord. It's a delicate and really fascinating arrangement.
So let's unpack that. The testes has a triple arterial supply. Why is that redundancy so important? Why not just one big artery?
Well, it's a built-in backup system, a fail-safe. You have to remember the trifecta. First, the main player, the testicular artery, which comes straight off the aorta. That's the powerhouse.
Okay.
Then you have the cremasteric artery, which is a branch of the inferior epigastric. And finally, you have the artery to the vars from the superior vesical artery.
And these smaller ones, they provide collateral flow.
Precisely. The testicular artery does most of the work, for sure. But the others, especially that artery to the vas, provide a crucial lifeline. It's the reason we can sometimes save a testes, even after a partial torsion.
I see.
And it's also the anatomical principle that makes some really complex surgeries, like the Fowler-Stevens procedure we'll talk about later, even possible. You're relying on that collateral capacity.
Okay, so the arterial side has this smart layered redundancy, but the venous side, that's a different story. It seems to introduce a major vulnerability.
Oh, it's a huge vulnerability.
Yeah.
The venous drainage is where the problems often start. It all begins with this network called the pampiniform plexus.
Which is more than just drainage, right? It has another job.
A critical job. It's a dense web of veins that acts as a countercurrent heat exchanger.
Yep.
Its whole purpose is to cool the arterial blood before it reaches the testes, keeping it a few degrees cooler than the core body temperature.
Essential for sperm production.
Absolutely essential. But the path that blood takes out of this plexus is asymmetrical. And that asymmetry is, well, it's a bit of a design flaw.
Okay, break down that distinction for us. Right side versus left side.
It's surprisingly simple, but has massive clinical implications. On the right side, the plexus drains smoothly, directly into the inferior vena cava, the IVC. It's a short, low-pressure, very efficient route.
And the left.
The left side is a different story. The vein on the left drains into the left renal vein, and it does so at a nearly 90-degree angle.
A right angle. That can't be good for flow.
It's terrible for flow. You have this sharp turn, plus the left renal vein can sometimes get compressed between the aorta and the superior mesenteric artery. That's the nutcracker phenomenon.
So you have higher pressure to begin with.
You have much higher pressure column, more venous resistance, and just overall less efficient drainage. It's a recipe for backup.
So if I'm hearing this right, this one anatomical quirk is the main mechanical reason why we see pathologies like varicocele, which is basically varicose veins of the scrotum, almost always on the left side.
That's exactly it. Gravity plus that high-resistance path creates stasis. The blood pools and the veins dilate. We will definitely come back to this when we talk about varicose seal, but understanding this anatomy right now tells you why it happens in the first place.
Incredible. Okay, let's shift from vascular to developmental anatomy, the descent of the testis.
Right, another critical journey. The timeline here is key. The testis needs to complete its descent from the abdomen down the inguinal canal and into the scrotum by about 6 to 9 months of gestation.
It needs to be in that cooler environment.
It has to be.
So what happens when that process gets stuck? When you have an undescended testis or cryptorchidism?
If that testis stops anywhere along its path, it could be high in the abdomen, stuck in the inguinal canal, or just high up in the groin, it remains exposed to that higher core body temperature.
And that's toxic to the sperm-producing cells.
It's toxic to the germ cells, yes. And critically, it's strongly correlated with a much higher risk of developing cancer later in life. That's really the foundation of why we treat cryptorchidism with such urgency. We are trying to prevent a future disaster.
So the location is everything. An undescended testis in the abdomen or inguinal canal isn't just a misplaced organ, it's a high-risk liability.
It's a ticking clock, a liability for both future fertility and, more worryingly, for malignancy. If it's not where it's supposed to be by about 6 months of age, we need to intervene.
Okay, so that leads us directly into management. Let's define cryptorchidism with a bit more precision, because I know there's a common condition, retractile testis, that can be confusing for parents.
Yes, and that distinction is so important for counseling. Retractile testis is one that pulls up temporarily because of a very strong cremastric muscle reflex, especially in kids. You can gently manipulate it down into the scrotum, and it's a benign, normal variant.
It doesn't require surgery.
No. A true undescended testis, on the other hand, is one that you cannot manually bring down into the scrotum. It has physically failed its journey and is stuck somewhere higher up. Once you've made that diagnosis, the risks become the driving force for surgery.
Let's walk through those 5 major risks. These are the reasons to operate.
Okay, number 1, the most obvious long-term risk is infertility. The higher temperature damages the germ cells. And even if you bring it down later, that testis may not function well. Plus, there's some evidence it can even affect the function of the contralateral healthy testis.
Okay, so infertility is number 1. What's next?
Number 2 is the big one, increased risk of malignancy. The risk is not small. We're talking 4 to 6 times higher than the general population.
And is there a specific type of cancer we're worried about?
Yes. The most common type that arises in an undescended testis is seminoma. That sustained higher temperature is thought to mess with how the germ cells mature, potentially pushing them toward malignant transformation.
So that risk, even more than fertility, is what really pushes the timeline for surgery.
Without a doubt. And it's important to know that bringing the testes down with surgery, an orchidopexy, doesn't eliminate the cancer risk completely, but it does 2 crucial things. It puts the testes in a healthier, lower temperature environment, and it makes it palpable so it can be easily examined for life.
Self-examination becomes possible.
Exactly. Okay, and what's left? We have 2 acute risks, both related to the fact that it's not properly anchored in the scrotum. That's torsion and trauma.
It's more mobile and more exposed.
Right. It's prone to twisting, and if it's lying over the pubic bone, it's very vulnerable to a direct blow. And then number 5, which is very common, is an associated indirect inguinal hernia. The same channel that the testes was supposed to come down, the processus vaginalis, fails to close, leaving a path for a hernia to form.
So clinically, you're looking for an empty scrotum, a non-palpable testes, and you noted it's statistically more common on the right side. Diagnosis is clinical, maybe an ultrasound to locate it if you can't feel it at all.
Correct. But the management decision is all about the clock. Spontaneous descent can happen, but we really only give it until 6 months of age.
And after 6 months.
After 6 months, the risk of ongoing damage is too high. Surgery, or orchidopexy, becomes the standard of care.
And orchidopexy just means surgically bringing the testes down and fixing it in place. But the technique you use depends entirely on where that testes is stuck.
Yes, its location dictates the complexity. If it's a low-lying testes, say just at the top of the scrotum or in the superficial inguinal pouch, you can usually do a single-stage mobilization. You dissect the cord, make sure you have enough length, and then you fix it in a small pouch in the scrotum.
But what if it's much higher? What if it's way up inside the abdomen and the spermatic vessels are just too short to reach?
Now you're in a much more challenging situation. This is where you need a specialized technique, the Fowler-Stevens procedure.
Okay, explain this in detail, because it sounds counterintuitive. My understanding is that you actually sacrifice the main blood supply. How does the testes survive that?
It is very counterintuitive, but it's an elegant solution. It's usually done in 2 stages. In stage 1, the surgeon, often laparoscopically, goes in and finds the testes high up in the abdomen.
Yeah.
They then identify the main testicular artery and veins and deliberately ligate and divide them.
You cut them.
You cut them high up near where they originate. And the reason you can do this goes right back to our anatomy discussion. You are banking on the collateral blood supply from the cremasteric artery and the artery to the vasces to keep the testes alive.
So you sacrifice the main highway and force the body to rely on the back roads.
That's a perfect analogy. You cut the main vessels, and then you wait. You give those smaller collateral vessels several months to hypertrophy to get bigger and stronger and take over as the sole blood supply.
And then you go back for stage 2.
Exactly. 3 to 6 months later, you perform stage 2. Now, the testes is only tethered by the vas deferens and its collateral blood supply. You no longer have the short, tight testicular vessels holding you back. This gives you much more length to mobilize the testes all the way down into the scrotum and fix it in place.
That's a high-stakes trade-off. You're risking testicular atrophy if those collaterals aren't robust enough.
You are. It's a calculated risk. But it's a risk you take to get the testes out of that dangerous intra-abdominal environment and protect the patient from a lifetime risk of malignancy. It's a beautiful example of surgical decision-making based on a deep understanding of anatomy.
Incredible. Okay, from a preventative long-term urgency, let's pivot to the most acute crisis in the field. The true surgical emergency where minutes, not months, matter. Testicular torsion.
This is where everything speeds up. Torsion is a vascular catastrophe. It's the twisting of the spermatic cord, which chokes off the blood supply.
Loss of blood flow means ischemia and, if not corrected, necrosis. The organ dies.
And the difference between saving it and losing it is often just a couple of hours.
Let's talk about the main predisposing factor. Surgeons always talk about the bell clapper deformity. It's such a specific, evocative name.
It is, and it perfectly describes the anatomy. Normally, the testis is anchored to the back of the scrotal wall by its mesentery. The tunica vaginalis, the sac around the testes, attaches firmly.
So it's fixed. It can't rotate.
Right. In the bell clapper deformity, that attachment is abnormally high up on the cord. This means the testes and epididymis are left hanging freely inside the tunica vaginalis, able to swing and rotate, like the clapper inside a bell.
It has a horizontal lie instead of a vertical one.
Exactly. And that free mobility, that horizontal lie, is what allows it to spontaneously twist on itself.
Now, sources suggest this deformity is often bilateral. If that's the case, why don't patients always get torsion on both sides?
That's a fantastic question. The anatomical predisposition is usually there on both sides, but the torsion event itself often needs a trigger. It could be a sudden movement during sports, minor trauma, even a strong muscle contraction during sleep.
So the anatomy creates the risk, but something else pulls the trigger.
Yes, but the bilateral risk is so high that it dictates our surgical management. When we go to the operating room to fix a torsion on one side, we always perform a prophylactic fixation, an organopexy, on the other, asymptomatic side during the same surgery to prevent it from ever happening there.
Let's paint the picture of the classic clinical presentation of torsion. What does the patient experience?
It's sudden. It's dramatic. The patient, often an adolescent, will report the sudden onset of severe, intense scrotal pain. It's often so bad it's associated with nausea and vomiting.
And on exam, what are the key findings?
The scrotum on that side will be swollen, red, and exquisitely tender. The testes itself is often high-riding, pulled up toward the groin because the twisted cord is now shorter. And the most crucial, classic physical sign for making a rapid diagnosis is the absent cremasteric reflex.
Explain why that reflex disappears.
The cremasteric reflex is when the testes on one side pulls up in response to stroking the inner thigh on the same side. The nerve pathway for that reflex arc, both the sensory and motor nerves, runs right through the spermatic cord.
So when the cord twists,
it cuts off the nerve signal, just like it cuts off the blood supply. The reflex is gone. It's a simple, powerful diagnostic clue that you can check for at the bedside.
okay, this clinical picture needs to be immediately differentiated from its main mimic, which is infection or epididymitis. This is where Preen's sign becomes the tiebreaker.
It's the classic textbook differentiator. Preen's sign is a simple maneuver. You gently elevate the patient's scrotum,
Okay.
If elevating the scrotum and providing support improves the pain, that is a positive preen sign. This strongly suggests the pain is inflammatory. From epididymitis. The elevation helps with venous drainage and relieves pressure.
An intorsion.
In torsion, elevating the scrotum provides no relief, and in fact, it might even make the pain worse. It's a mechanical problem, a strangulation, and elevation does nothing to fix it. So pain relief on elevation points to infection, no relief points to torsion.
And that diagnosis is what starts the clock. You've stressed this time window is everything. How fast does a surgeon really have to move?
You are literally in a race against tissue death. The golden period is less than 6 hours from the onset of pain. If you get the patient to the OR and untwist the cord within that window, the salvage rate is somewhere between 90 and 100%.
And after 6 hours?
The viability drops off a cliff. After 12 hours, the salvage rate can be less than 20%. Beyond 24 hours, it's almost always a dead, non-viable testes that has to be removed.
That urgency seems to override everything. So if a patient comes in with that classic story sudden pain, high-riding testes, absent cremasteric reflex, is there ever a reason to delay things for, say, a Doppler ultrasound?
The classic teaching and the directive from our source material is crystal clear. Do not wait for imaging in classical cases. You go directly to the operating room. Exploration is both diagnostic and therapeutic.
But what if the OR isn't immediately available or the picture is a little bit ambiguous?
In that situation, you might get an ultrasound to confirm the lack of blood flow. But even then, there's something you can try in the emergency department. Manual detorsion.
You try to untwist it by hand.
Yes. You can try to rotate the testes outwards, toward the thigh, like opening a book. Most torsions are intravaginal, twisting inwards. If you successfully untwist it, the patient often feels immediate dramatic pain relief. But it's crucial to understand this is only a temporary bridge to the OR. It's not a definitive treatment. You still need to go to surgery to confirm viability and perform that bilateral fixation.
Okay, let's contrast all of this with the other, less urgent, but much more common cause of scrotal pain, epididymoorchitis, the infection.
The presentation couldn't be more different. Torsion is a thunderclap. Infection is a slow burn. It has a gradual onset over a day or two. The patient develops scrotal pain, swelling, and often systemic signs like fever and chills. And of course, they should have that positive pre-sign we talked about.
And the cause of the infection is heavily dependent on the patient's age. This is key for choosing the right antibiotics.
Absolutely. In sexually active men, generally under 40, you have to assume it's a sexually transmitted infection. We're primarily thinking of chlamydia trachomatis or Neisseria gonorrhea.
So the antibiotic choice has to cover those organisms.
Yes, something like ceftriaxone plus doxycycline or azithromycin. However, in older men, say over 40, the cause is usually different. It's typically urinary pathogens, enteric organisms like E. coli that have tracked backwards from the urinary tract. This is often associated with things like an enlarged prostate, BPH, or recent bladder catheterization.
And in that case, you'd use a different antibiotic, like a fluoroquinolone.
Exactly. The management is entirely medical. The right antibiotics, scrotal elevation to help with the swelling, anti-inflammatories, and analgesics. No surgery is needed unless a complication like an abscess develops.
Okay, let's move away from the acute crises and into the more chronic, common scrotal swellings. We'll start with the fluid collections, with hydrocele.
Right. A hydrocele is, at its simplest, a collection of fluid in the space around the testes, within the tunica vaginalis.
But the different types of hydrocele all relate back to a piece of developmental anatomy, the processus vaginalis.
Yes, you have to understand the processes to understand hydroceles. The processus vaginalis is basically a finger-like projection of the peritoneum, the lining of the abdomen, that travels down with the testes during its descent.
And it's supposed to close off.
It's supposed to obliterate completely, leaving just a small, sealed sac around the testes called the tunica vaginalis. When that obliteration process fails, you get the different kinds of hydroceles.
So let's break down the four main types based on where that failure occurs.
Okay, the most common type in adults is a simple vaginal hydrocele. This is where the processus is closed off properly, but for some reason, the tunica vaginalis itself starts overproducing fluid or not reabsorbing it properly. The fluid is trapped right around the testes.
And what about an encysted hydrocele of the cord?
That's when the processus closes at the top near the abdomen and at the bottom near the testes, but a little segment in the middle stays open and fills with fluid. So you get a little fluid-filled cyst somewhere along the spermatic cord.
And then you have the types that are more common in children, which involve a connection to the abdomen.
Right. An infantile hydrocele is when the process is still open all the way up to the deep inguinal ring. but it's sealed off from the main abdominal cavity. So fluid is trapped along the whole length of the cord. But a congenital hydrocele is the truly communicating type. Here, the processus vaginalis is wide open, creating a direct channel between the abdominal cavity and the scrotum.
So the fluid can actually move back and forth.
Yes, which is why with a congenital hydrocele, the swelling can famously change size. It might be smaller in the morning after the child has been lying down, and bigger in the evening after they've been up and active.
For all these types, though, there's one simple clinical test that's the key differentiator.
Transillumination. It's a classic. You take a pen light or a torch, hold it against the back of the scrotum in a dark room, and if it's a simple hydrocele, the whole swelling will light up with a red glow.
Because it's just fluid.
It's just clear fluid. A solid mass, like a tumor or a hernia-containing bowel, will not transilluminate. It's a vital bedside test.
In management, it's not always surgical.
Not at all. For small, asymptomatic hydroceles in adults, we just observe them. Surgery, a hydrocelectomy, is really only for cases where the size is causing pain or discomfort, or for congenital communicating hydroceles in children, which have a high risk of developing a full-blown hernia.
Okay, let's quickly touch on the other cystic swellings, spermatocele and epididymal cyst.
They're very similar. Both are benign cysts that you can usually feel separate from the testis itself, often at the top. The key difference is the fluid inside.
A spermatocele has sperm in it.
Right. It arises from the head of the epididymis, from the tubules there, and the fluid is milky or cloudy because it's full of spermatozoa. An epididymal cyst, on the other hand, just contains clear, serious fluid.
But clinically for the patient, is there much of a difference?
Not really. The distinction is mainly for the pathologists. For the patient, they're both benign lumps, and we only excise them if they get large enough to be painful or bothersome. Okay, now we have to circle back to our venous anatomy to really understand varicocele. The bag of worms.
Right. This is where that whole discussion about the left renal vein comes back into play. A varicocele is a dilation of that pampiniform venous plexus.
And it's almost always on the left side, precisely because of that high-pressure drainage system we talked about. The backup of blood causes the veins to get engorged and dilated.
And the most serious potential consequence of this is not pain, but infertility.
That's the main reason we treat it. That pooling of warm, deoxygenated blood in the plexus disrupts the countercurrent heat exchange. This raises the temperature in the scrotum by a degree or two, which creates oxidative stress and is toxic to sperm development. It leads to lower sperm counts, poor motility, and abnormal morphology.
What are the classic findings on a physical exam?
The description is unforgettable. It feels like a soft, compressible mass above and behind the testes, a bag of worms.
I've always heard that phrase.
It's very accurate, and characteristically, it becomes much more prominent when the patient is standing up due to gravity, and it will swell significantly when they perform a Valsalva maneuver bearing down like they're having a bowel movement. That increases the back pressure and makes the veins pop out.
And the decision to operate is often tied to a clinical grading system.
Yes, the grading is important. A grade I varicocele is the smallest. You can only feel it when the patient does the Valsalva maneuver. A grade 2 is palpable even at rest while standing. And a grade 3 is so large that it's clearly visible through the scrotal skin.
So who gets surgery?
Generally, we operate on patients with a grade 2 or through varicocele who also have documented infertility, meaning an abnormal semen analysis, or if there's evidence that the testes on that side is smaller or failing to grow, or if the patient is having significant pain. An asymptomatic grade I usually doesn't require intervention.
And for those who do need surgery, what's considered the gold standard technique now?
The most effective method with the lowest recurrence rate is microsurgical subinguinal varicocelectomy.
Microsurgical. So you're using a microscope.
Yes, you're working under high magnification. This allows the surgeon to be incredibly precise. You can meticulously identify and ligate all the tiny, dilated internal spermatic veins while, crucially, preserving the single testicular artery and the lymphatic channels.
Why is preserving the lymphatics so important?
Because if you damage them, the patient is at high risk of developing a postoperative hydrocele, which used to be a very common complication of the older, less precise surgical techniques. The microscope makes the operation safer and more effective.
Okay, that covers the chronic issues. Now we need to make a sharp turn into another life-threatening emergency, one that is truly terrifying: Fournier gangrene.
This is one of those destructive and rapidly progressing conditions in all of surgery. Fournier gangrene is a specific type of necrotizing fasciitis, a flesh-eating infection that targets the perineum, scrotum, and genital area.
It's not just a skin infection.
No, this is not cellulitis. This is an infection that dives deep and destroys the fascia, the connective tissue planes under the skin, allowing it to spread with terrifying speed. One interesting point is that it often spares the testicles themselves because they have that separate deep blood supply we discussed.
And the infection is polymicrobial. It's not just one bug.
It's a synergistic gang,
Correct.
a deadly combination of aerobic bacteria like E. coli and anaerobic bacteria like Macrolides or Clostridium. They work together. The aerobes use up the oxygen, creating the perfect environment for the anaerobes to thrive.
And it's the anaerobes that produce gas, right, which gives you a key physical sign.
Exactly. The anaerobes ferment the dying tissue and produce gas that gets trapped under the skin. This leads to the horrifying physical finding of crepitus, a crackling or popping sensation when you press on the skin. It's a sure sign of deep, necrotizing infection.
Paint the clinical picture. What does the patient look like?
These patients are sick, systemically ill. They present with high fever, signs of sepsis, and pain that is often described as being completely out of proportion to what the skin looks like initially. The scrotum might just look a bit red and swollen at first, but the patient is in agony. That discrepancy is a huge red flag.
Mortality is high if you don't act fast.
Frighteningly high,
Yeah.
especially in patients with risk factors like diabetes or immunosuppression. Delaying treatment is a death sentence.
So what is the absolute non-negotiable management?
It has to be immediate and aggressive. The cornerstone is emergency surgical debridement. This is not a subtle operation. You take the patient to the OR immediately and you cut away all the dead necrotic tissue until you reach healthy bleeding margins.
It sounds incredibly disfiguring.
It can be. You have to remove all the infected tissue to stop the spread of toxins and save the patient's life. At the same time, you're hitting them with powerful, broad-spectrum IV antibiotics that cover both aerobes and anaerobes. And they need intensive supportive care in an ICU setting to manage the sepsis and shock.
The sheer severity of Fournier gangrene, that need for immediate, decisive action, actually sets the stage well for our final topic, which is another high-stakes area, testicular tumors.
Right, moving from an acute threat to life to a more insidious but equally deadly one.
Testicular cancer isn't common overall, but it's the most common solid cancer in young men, typically between 15 and 35, so understanding it is critical. Let's start with the main categories.
The vast majority, over 95%, are germ cell tumors or GCTs. These arise from the cells that produce sperm. And we split these into two main groups, seminomatous tumors and non-seminomatous tumors, or NSGCTs.
What about the other 5%?
Those are much less common. You can have sex cord stromal tumors, which arise from the supportive tissues of the testicle. And importantly, in older men, say over 60, the most common testicular mass is actually not a primary tumor, but a secondary one, usually lymphoma.
Let's focus on the GCTs. What's the classic and often subtle presentation?
The classic sign is a painless, firm lump or swelling in one testis. This is key. Unlike torsion or infection, it doesn't hurt. It's often found by accident in the shower, or the patient might notice a feeling of heaviness or fullness that's developed slowly over weeks or months.
Are there any other signs to look out for?
Yes, sometimes the tumor can produce hormones. If it makes OHCG, which is the same hormone associated with pregnancy, it can cause gynecomastia or breast enlargement in men. That can be a presenting sign.
Okay, now, before we even get to diagnosis, there is a critical rule, an absolute contraindication for how you investigate this lump.
This is probably the single most important do not do in urologic oncology. Do not perform a transscrotal biopsy
Never stick a needle through the scrotum. Why is that so dangerous?
because you risk seeding the tumor. Testicular tumors have a very predictable lymphatic drainage pattern. They drain upwards along the spermatic cord to the retroperitoneal lymph nodes deep in the abdomen. The scrotum, however, drains to a completely different set of lymph nodes, the inguinal nodes in the groin. If you stick a needle through the scrotal skin into the tumor, you risk dragging tumor cells out and seeding them into the scrotum and its lymphatic channels.
So you've just opened up a brand new, unnatural pathway for the cancer to spread.
You've instantly contaminated a new field. It automatically upstages the disease, requires a much more extensive and morbid surgery later, including removing the entire scrotal half, and it can worsen the patient's prognosis. All diagnosis and treatment must be done through an incision in the groin.
So if biopsy is out, what are the pillars of diagnosis and staging?
There are three. First, serum tumor markers. We draw blood to check for alpha-fetoprotein, AFP, beta-human chorionic gonadotropin, Yersin CG, and lactate dehydrogenase, LDH. Second, a scrotal ultrasound. It's brilliant at confirming that the lump is solid and inside the testes. And third, for staging, a CT scan of the abdomen and pelvis to look for any spread to those retroperitoneal lymph nodes.
Let's break down the tumors themselves. We'll start with seminoma, the most common type.
Seminoma is the classic GCT. It tends to occur in men in their 30s and 40s. Histologically, it's very uniform, but the key clinical features are that it is highly radiosensitive and chemosensitive. This gives it an excellent prognosis, even if it has spread.
And what about its tumor markers?
This is a critical point.
Right.
A pure seminoma will never produce AFP. If the AFP is elevated, you know there has to be a non-seminomatous component mixed in. About 10 to 15% of seminomas might produce a small amount of HCG, but it's usually a mild elevation.
Okay, let's contrast that with the non-seminomatous tumors, the NSGCTs. This is a more diverse group: embryonal carcinoma, yolk sac tumor, choriocarcinoma, teratoma.
Right, and as a group, NSGCTs are generally more aggressive than seminomas. They tend to grow faster, metastasize earlier, and present a tougher challenge. Their marker profile is also much more varied and critical for diagnosis and for monitoring treatment.
Let's detail those specific marker correlations. It's almost like a fingerprint for the tumor type. And you have to consider the half-life of these markers too, right?
Absolutely. The half-life is crucial for follow-up. A yolk sac tumor, which is the most common testicular tumor in infants and children, produces a very high level of AFP. The half-life of AFP is about 5 to 7 days.
Okay.
Choriocarcinoma is the most aggressive and rare type. It produces massively high levels of BHTG, which has a much shorter half-life of about 24 to 36 hours. Embryonal carcinoma, another very aggressive type, can produce both AFP and HCG. And then you have teratoma, which is a strange one. It's often marker negative, but is resistant to chemotherapy and radiation.
And the half-life matters because after surgery, you expect those markers to drop at a predictable rate.
Precisely. If they don't fall as expected based on their half-life, it tells you there's still cancer left somewhere in the body.
So once the ultrasound and markers point strongly to cancer, what is the mandatory first step in management for any type?
The first step is always the same: radical inguinal orchiectomy.
Explain what that involves.
You make an incision in the groin, like for a hernia repair. You go in and you find the spermatic cord and you clamp it high up at the internal ring before you ever touch or manipulate the tumor itself. This prevents any tumor cells from being squeezed into the bloodstream during the operation. Then, you deliver the entire testes and cord out through the inguinal incision and remove it.
So it's both diagnostic and therapeutic.
Exactly. It removes the primary tumor, and it gives the pathologist the entire specimen to determine the exact histology and stage.
And what happens after that? The subsequent treatment must be highly individualized.
Completely individualized. It depends entirely on the pathology: seminoma versus non-seminoma, and the stage from the CT scan. For a stage A seminoma, with no spread, the prognosis is so good that active surveillance might be an option, or a single insurance dose of chemotherapy with carboplatin. For a stage I NSGCT, because it's more aggressive, most patients will be offered a short course of chemotherapy, usually with a regimen called BEP, bleomycin, etoposide, and cisplatin, or a retroperitoneal lymph node dissection. It's a complex decision tree based on risk factors.
A really comprehensive overview. We've covered a huge amount of ground today.
We really have. From the basic plumbing of the left renal vein that explains varicocele, all the way to the molecular fingerprints of tumor markers.
The journey has been really logical, I think. We connected that 6-hour golden window for torsion to the absolute rule against transscrotal biopsy for tumors. We've seen how a failed developmental process, the closure of the processus vaginalis, explains the whole spectrum of hydrocele.
And it all followed that very clear, efficient structure laid out by Dr. Senthil Kumaran, which itself was inspired by those effective teaching methods from Mr. Nilesh Lodhajisar. It's a framework designed to make complex information stick.
It is. And thinking about the urgency we've discussed today, the rush to detorse a testis or the emergency debridement for Fournier gangrene, it really brings up a bigger systemic challenge.
It does. These are not conditions where you can wait.
Exactly. So what's your final provocative thought for our listeners today, connecting this deep dive to some of the realities of healthcare delivery?
My thought is this. Given that immediate, skilled surgical intervention within a golden period is the difference between saving a life or preserving fertility, how do we translate this knowledge into practice in all settings? How might surgical readiness, training on basic but critical skills like ultrasound or assessing preens sign, and efficient triage protocols need to be adapted and implemented in remote or under-resourced medical environments where a specialist team and an open OR aren't available 24/7?
It forces us to think about how we can take these high-level surgical standards and make them a timely, accessible reality for everyone, everywhere.
That's the challenge.
A really profound operational question for anyone in global health or emergency planning. We encourage you to think on that as you integrate what you've learned today. Thank you for joining us on the deep dive.